Thank you, everyone, for joining us. It is so good to have you with us. Thank you for just taking the time. And today we're going to be discussing our key learnings and future directions to advance health priorities that matter to the intellectual and developmental disabilities community. I am Dr. Michelle Scotton Franklin, and I am an assistant professor at the Duke Department of Psychiatry and Behavioral Sciences and Duke Margolis Institute for Health Policy. This webinar is our final meeting for the project that Dr. Bristana Kaufman and I co-led, titled Engaging Adults with Intellectual and Developmental Disabilities to Inform a Patient-Centered Home Time Outcome. We are grateful for the Patient-Centered Outcomes Research Institute Engagement Award that made it financially possible to include adults with intellectual and developmental disabilities, family caregivers, and other disability advocates from across the United States throughout this project. During our time together today, we will provide a brief summary of our findings. You will also get to hear from experts from across the country about ways that these findings can help guide our future research and policy design with the intellectual and developmental disability community. All right, it is my pleasure to introduce our first speaker, the Honorable Zach Hawkins. Representative Hawkins made history in November 2018 by becoming the youngest person elected to the North Carolina House of Representatives to represent Durham in North Carolina's House District 1. Since taking office, he has consistently demonstrated his strong belief that everyone deserves the opportunity to contribute. He's been a strong advocate for well-funded and affordable education, accessible healthcare, living wage jobs, and a trustworthy state government that serves the best interest of its citizens. Through his various roles, which include co-chairing the bipartisan IDD caucus for representatives and senators, as well as serving as a member of the North Carolina Council on Developmental Disabilities, he is an exceptional advocate for the more than 230,000 individuals with IDD and their families living in North Carolina. Representative Hawkins is also a native North Carolinian and the father of 2 sons with autism. And I am grateful to be able to witness firsthand his deep commitment to our state and to the IDD community. All right, Representative Hawkins, thank you for taking the time to speak with us, and I turn it over to you.
Thank you. Thank you, Dr. Franklin. It brings me great joy to offer opening remarks ahead of this important and timely conversation. As you said, my name is Zach Hawkins, and I proudly serve Durham County in the state house. And Durham is a community grounded in innovation and equity, a city that really listens, especially to the voices of those that are historically been left out of systems of care. Literally, we're the city of medicine. As a father of 2 sons with autism, I don't carry this work just professionally. I carry it very personally. I know what it means to advocate, to navigate broken systems, and to imagine a better future for our children. I do it every day. That's what makes today's discussion urgent and so close to me in my heart. Our IDD community in North Carolina is vibrant, resilient, and full of leadership. Families advocate fiercely for their loved ones. Organizations like the Arc of the Triangle, Triangle Disability and Autism Services, the Council on Developmental Disabilities work tirelessly to support individuals and their loved ones. And institutions such as Duke University are doing groundbreaking research that centers on their life experience, helps make sure that we redefine what health equity truly means for people with IDD. This work has shown us that a good day for people with IDD means several fundamental things: living in the home of your choice, participating meaningfully in your community, accessing healthcare that understands your whole person, having coordinated support for trusted caregivers, and being able to access services that are responsive to your unique needs. We are committed to making these tenets real through focused legislation and investment in the General Assembly. Living in your home of choice is foundational. That's why ending the innovations waiver waitlist is such an urgent and pressing issue for us. This program gives thousands the chance to live independently, not just institutions, surrounded by familiar people and support. It's the ability to have autonomy, but most importantly, dignity. Being able to participate fully in community life means having access to transportation, educational inclusion, and opportunities to work and volunteer. Our legislation is pushing for expanded integrated services and protections that ensure that students with IDD are supported and their needs are addressed. Healthcare must be disability informed and whole person focused. House Bill 933, which is the IDD Omnibus Bill, includes provisions for better training for providers to ensure that people with IDD are treated with respect and receive care that meets their unique needs. No one should ever be dismissed or misunderstood in medical settings. Supporting people every day depends on direct support professionals, or DSPs as we call them, who understand their role as partners in care. Increasing DSP pay is a key priority because without these essential workers, individuals cannot thrive in their homes and community. We had great success in our last term, and we're really holding out on this current term. Finally, access to responsive and flexible IDD services means bringing people, making sure they have the power to direct their own care and make their own decisions. It means helping families and individuals find the right support at every stage, including during the transitions as they age, much as my few boys. The tenets aren't just policy goals. They're about respecting the agency and humanity of every person with IDD. The stories we hear in Durham and across North Carolina, from individuals creating their own schedules, to families advocating for inclusive education, to advocates fighting for justice, remind us why all of this matters and why this research and why focused legislation is so important. We are building policies that reflect these values. We're investing in housing, in education, in healthcare, and workforce that brings a good day within the reach for more people. The voices of people like Janie, Olivia, and Betsy, whose experiences are beautifully outlined and shared in the upcoming video, remind us that this fight is all about them. It's about agency, self direction, and being able, as Janie said more powerfully than I could, it's about being your own boss. That sentiment echoed through our IDD listening session at the General Assembly just a few months ago. We had over 200 parents, educators, advocates, and self advocates show up to share their truth. This was the first time, the second time actually, this had ever happened in North Carolina history, where people were able to come and share their truth directly to legislators. The work of the institutions like Duke and the Margolis Institute, where researchers are redefining home time, not just as a day spent out of facility, but days lived with meaning and independence. That is what helps build evidence around what the IDD community has long said. A life of quality is not defined solely by health outcomes, but by purpose, connection, and choice. So, yes, we're talking about policy today, but make no mistake, this is all about the people. People who deserve to wake up in the home of their choosing, create their own schedules, make their own mistakes, and live lives on their own terms. I'm so grateful to Duke University and Margolis Institute for Health Policy and all the partners who center the voices of those that matter most. Together, let's listen with empathy, act with urgency, and continue building a better North Carolina where inclusion is the promise kept every single day. And so, one of the key goals of this work is to center the voices with people who've lived and engage every day with this work. And one thing that I want to say about Margolis is that they, in their research, have co-created this research and built priority that matters most to the people who are impacted. And to do this today, I'm pleased to introduce you to three community members from North Carolina, Olivia Rose Scott, Janie Desmond, and Betsy McMichael. They shared their stories as part of the project team to highlight the lived experience of those with IDD seeking healthcare. You'll see that in the next video.
I see my primary care provider regularly. I have therapy about once a week. Um, but it's been a struggle to get the health care that I need because sometimes I'm too depressed. In the past, I've been too depressed to get the health care that I need. Yes, you took the requisite coursework to gain those letters, but um at the end of the day, I'm the one with the autism and with the mental illness. Like, you just get to ride the bus with me. I'm the one driving it. I do have an endocrinologist. I've only seen him once so far, so he's new to me. He seems to be pretty good at what he does. My first endocrinologist, but that was all the way out in Kinston, and I needed definitely something closer to home. So being able to have a provider here in Goldsboro has been really helpful towards that. Yeah, the hospital setting is different. They woke us up at 5:30 in the morning to get our vitals done. 5:30 in the morning to get my vitals done. Can we not wait until, I'm a little bit more awake? That's definitely different from an in-home setting where I can sleep decently for a certain amount of time and not be woken up like, hey, we need your vitals, Miss Scott.
When I was in the ER for my foot infection, I had the best doctors. I mean, the nurses. They came in so quickly. They did their job. Yeah, I just love how they just got me what I needed. I was just like, okay, Mom, Dad, are you here? Where are you? When I was in the emergency room that night, my dad took me. I was fine. And then when I was able to go to the, you know, ED to like get admitted, I was like, okay, what, are you coming with me?
That's really interesting. I find, and my husband agrees, that we really can't leave Janie alone at the hospital. As you can see, she speaks well, she's a good communicator, but I think because her particular health history and sort of collection of challenges is so complex medically, we find that one specialty area doesn't talk to the other necessarily, and everybody's trying to do their best, but often we will have to be there to interject some important information from the past.
The hospital stays I have to do is annoying because sometimes I have to stay there till the next morning, and I'm like, I didn't sign up for this.
I've spent the night on site in psychiatric facilities about 4 times here in North Carolina, 4 or 5 times here in North Carolina. The experience as an adult has always been re-traumatizing. I don't think I had seen my partner for about a week, maybe a week and a half, because COVID lockdowns. And when I got out of the hospital, the joy of seeing my partner and his joy at seeing me come out of the hospital, oh my goodness. There was just so much joy.
Thank you, Representative Hawkins, for your remarks, and Olivia Rose and Jamie and Betsy, who shared their stories with us through that video. I will note that that was just a portion of the video that we created for this project, and we will share a link where you can access the full video to hear more from our community members. And just for awareness, I'm Monty Smith, Policy Research Associate with the Duke Margolis Institute for Health Policy. And I'm going to spend the next 7 or so minutes to try and breeze through some more information about our project,
and some key learnings so that we can then listen to a wonderful panel of experts to continue to speak to these research priorities that have already started to come up during discussion. And wanted to start off by just thanking the broader team that has supported this work, including some senior advisors from Duke University who have been really influential as we have developed this project. And I really want to highlight the advisory council that was invaluable to not only the content creation of this work, but also the planning and recruitment that went into this engagement project. You'll notice that we have self-advocates, family caregivers, as well as other experts who just continued to iterate with us and contributed their time over the last year. I also want to introduce the health outcome measure that this project served to explore with the IDD community. So days in the community or home time is the number of days that a person is not in a hospital, a nursing home, or a healthcare facility. It's seen as a person-centered measure because it captures people's desires to be at home where they have more independence. And there's research that shows that people who spend more days at home have a better quality of life. So counting the number of days that a person is out of a healthcare setting is seen as a way of measuring how a health system is meeting the needs of populations. However, this measure has not been explored with the IDD community, which our project served to start doing. So over the course of the last year or so, our project really served to understand the experience of home and in different healthcare settings for the IDD community to ultimately co-create research priorities for future research that better measure health outcomes that are patient-centered and matter to adults with IDD. This slide summarizes a lot of findings in a really short period of time with little text. And so I will point you all to our webpage where you can hear more about what we heard from community members about their experiences across different healthcare settings, as well as what supports they need at home to be safe and independent and live in their home of choice. But here we wanted to summarize a few themes that emerged from community members, regardless of the healthcare setting. And that those settings ranged from emergency departments, hospitals for acute care, as well as for mental health care, intermediate care facilities, and nursing homes. And we heard a lack of autonomy and respect with adults with IDD feeling like they just didn't have a say in their care or they weren't listened to by healthcare providers. You heard Olivia Rose speak to this by having to wake up at 5 a.m. for her vitals, for example, rather than when she would naturally wake up at home. We heard broader communication challenges with adults with IDD not having the adequate time with healthcare teams to share their experiences or not able to access healthcare team members. We heard about inadequate training across the healthcare team to provide that disability-informed healthcare that Representative Hawkins was speaking to earlier. And then we also heard challenges accessing care. So whether that's a limited supply of disability-specific services or broader challenges accessing primary care. Accessing mental health care services was echoed by our community members throughout meetings, with one self-advocate sharing that in her state, mental health facilities won't admit people who require assistance with activities of daily living, for example. We also heard positive experiences seeking healthcare, and this slide summarizes kind of 3 themes that we heard help contribute to a positive experience. The first is having a provider who knows your medical history, so established relationships with healthcare providers. We heard the importance of healthcare providers who are not only knowledgeable of the IDD community, but are comfortable providing that disability-informed care. And finally, we heard providers who go out of their way to help minimize disruption to the person with IDD's life and proactively coordinating care. And this figure summarizes what Representative Hawkins was giving a wonderful summary to at the beginning of the webinar around what we heard from community members for a good day at home. And you'll notice that a good day really starts by being in one's home of choice, being able to participate in their community, whether that's through work or a job or advocating for the community. Again, being an active participant and guiding those coordinated supports if desired around, healthcare providers, the whole healthcare team, direct support professionals, family caregivers. A good day means benefiting from disability-informed whole person healthcare. And finally, a good day means accessing those IDD services that are responsive to a person's needs. And finally, before I hand it over to Dr. Sam Franklin to introduce the panel, I wanted to highlight the 3 research priorities that we identified through our engagement project. The first being engage people with lived experiences to co-create patient-centered outcomes that focus on the health priorities that matter to the community being served. In the context of this project, that was the IDD community, and particularly in the context of aging. The second priority is to conduct research to evaluate healthcare interventions intended to support people with IDD and caregivers as they age and as they age together. And finally, tailor the home time measure to ensure that it captures the experiences of the IDD community. And with that, I'm going to hand it back over to Dr. Scott and Franklin to introduce our panelists.
Right. Well done, Monty. That was a quick summary of a lot of work, a lot of great information. So our panel today will discuss strategies to help adults with IDD achieve health priorities that, again, really matter to them and to support families aging together. I'm really excited to introduce our panel. I will start with first Sarah Triano. She is the Associate Director of Long-Term Services and Supports and Disability Policy at the Center for Healthcare Strategies. She proudly identifies as a person with physical and mental health disability, is the mother of 2 disabled children, and she is a caregiver for her mother, who also has a disability. Previously, she served as the Senior Director for LTSS and dually eligible products for a Medicaid managed care company. She was also Disability Policy Advisor to California's Health and Labor Secretaries and the Executive Director of a Center for Independent Living run by staff and board members with disabilities in California. Next, Dr. Harold Pollack is the Helen Ross Distinguished Service Professor at the University of Chicago's Crown Family School of Social Work, Policy, and Practice. He is the co-founder of the University of Chicago Crime Lab and faculty co-director of the University of Chicago Urban Health Lab. His current research seeks to improve services and behavioral crisis response for persons living with mental health and substance use disorders, and for people who live with intellectual and developmental disabilities. Dr. Pollack is also a co-guardian of an adult who has Fragile X syndrome. Next, we have Dr. Kenton Johnston. He is an associate professor at Washington University School of Medicine in St. Louis and is the associate director for research at the Center for Advancing Health Services Policy and Economics Research. Prior to coming to Washington U, he worked as an associate professor of health management and policy at St. Louis University and in medical informatics at Blue Cross Blue Shield of Tennessee. His research focuses on people with disabilities and neuropsychiatric conditions in the Medicare and Medicaid programs. We also have Dr. Courtney Van Houten. She's a professor in the university, she's a professor here at Duke University in the Department of Population Health Sciences, as well as the School of Medicine and Duke Margolis Institute for Health Policy here in Durham, North Carolina. She examines how family caregiving affects healthcare utilization, expenditures, health, and work outcome of care recipients and their caregivers. She's also interested in understanding how best to support family caregivers to optimize caregiver and care recipient outcomes. Last but not least, I'm pleased to introduce our panel moderator, Tally Wells. He is an attorney and leads the North Carolina Council on Developmental Disabilities here in North Carolina, and he works so hard to ensure that people with intellectual and other disabilities can live full and meaningful lives in their home community. Previously, he was the executive director of Georgia Appleseed and the Disability Integration Project at Atlanta Legal Aid Society. He also founded olmstedrights.org and the Olmsted Disability Rights Clinic at Georgia State School of Law. We appreciate you, Tally, for guiding our discussion today, and I will turn it over to you.
Thank you so much, Michelle, and thank you. You've given me an opportunity to give a few opening remarks before the panel, and I just want to say how much I appreciate this opportunity and how much I appreciate this research. Home is at the heart of everything disability rights advocates have been pushing for and advocating for throughout the last century and up until today and into the future. And home is where we all want to be. Home is, it is so obvious what you are researching, and yet we have built system after system after system to keep people from their homes and having that home time experience. How many of you who are here today with us hope when you retire you get the opportunity to live in a nursing home or a nursing facility? How many would like to live in an institution for developmental disabilities or a psychiatric hospital as the place that you go to bed every night, or the hospital, versus living and experiencing your life and whatever health treatment and other things that you need in your own home? So that's what we're talking about here. We're talking about what we all want. My dad went to visit a very close friend of his recently. My dad's 86 years old, who was in a nursing facility. And he told my sister, who's a doctor, I don't want to ever be here. I have a friend, our council chair here at the North Carolina Council on Developmental Disabilities, where we advocate for people to live full and meaningful lives, John D'Angelo, who just wrote an article because we have an 18,900 person waiting list here in North Carolina for developmental disability services. John has an extraordinary job, an extraordinary life, but he needs support with all activities of daily living, getting in and out of the bathroom, going to his job. And he faces the very real possibility, particularly in this moment where Medicaid is at risk, where Medicare is now on the table, of not always being able to live in his own home. He's in his early 30s. This is true for so many people. So I'm so excited to have this panel. And I'm so excited to be able to hear from each of our panelists today to really talk about why it's so critical to center academic research around what people want, who people are, the lived experience of folks. And each of our panelists today has their own lived experience, just like Representative Hawkins does, and all of the folks who have been part of this discussion. And I'm so excited to see all of the folks in the video. And I really would encourage everyone to watch the video. So I first want to start out with our panelists and just ask each of you to share a little bit about your own sort of lived experience and how that has influenced your work, because you're researchers, you're not advocates like me, but how it's influenced your work and what the role, what you see as some of the most critical issues impacting the disability community related to home. So Harold Pollack, I see you first, so I'd love for you to start.
Thanks so much, and thanks for it's a pleasure to be here. So I come to these issues with really several specific matters that are important to me. One of them is understanding and addressing the administrative burdens that face so many people with IDDs and their families as they try to navigate service and healthcare systems. For the past 21 years, my wife Veronica and I have been co-guardian of her brother Vincent, who lives with Fragile X syndrome, as was mentioned. And I'm a relatively privileged person. I'm a professor at the University of Chicago, and I think a lot about the same and different experiences that I have dealing with these systems, which in many ways are tuned for families like ours who have the information and resources to really navigate them. If I jump on a Zoom that says, here, we're having an educational forum for how you can help your family member make the best use of Medicaid. I get on it, and most of the other people on it are people like myself. They're middle-class people caring for a sibling or a child. We did a study here in Illinois of ABLE accounts, which are ways that people can get around can save for their futures and get around the $2,000 SSI asset limit. And we found in Illinois, most of the ABLE accounts were in the most affluent communities of the state. They were held by young adults with intellectual disabilities from upper middle class families. Uh, so we have to do a much better job of here in Illinois, and I'm sure across the country, in really helping all families. The other thing that's really important is to take that life course perspective, as you mentioned. Vincent's 59 years old. When I talk to a lot of people in my community, when they think about people with IDDs, they think about children, adolescents, young adults, and the need to have a plan cover that for over the full lifespan that is supported by healthcare providers, by service professionals, is critically important and is often overlooked. And one issue that Kenton and I have been researching is the high prevalence of early dementia among people with Down syndrome, for example. There's 80-year-old caregivers who are living with their son who's experiencing dementia. And so there's a lot to do there. So I went on at length, so I'm going to stop there.
Well, that was perfect. Thank you. And since you called on Kenton, I was going to call on you, Sarah, next, but I'm going to move over to Kenton just since y'all have been doing some research together. And Kenton, if you don't mind sharing a little about your own personal experience and what you think are some of the critical issues for this community.
Sure. Thanks so much for the opportunity to join this panel. I think it's really important. Thanks for the shout out, Harold. That's a great segue actually to I think really highlights the experience of adults with intellectual and developmental disabilities. And so my personal connection to this is I've been part of an intentional community in St. Louis that exists all over the nation and world, both as volunteer, as a worker at one time, called L'Arche. And L'Arche is an intentional community for people with and without intellectual disabilities, mostly made up of adults. And actually today, earlier this morning, sadly, I just attended the funeral of a gentleman from this community, wonderful gentleman, name is Jimmy, and Jimmy passed away at age 71 with Down syndrome. And, in his generation, the baby boom generation, I think that it's pretty unheard of, and people weren't really expecting people like Jimmy to live to age 71. But as being part of the L'Arche community, I think one of the things that highlighted for me is, if going to his funeral today, there were probably 1,000 people there in the church from all walks of life, a lot of people who were direct support workers to Jimmy, and then family members and friends. And it's such an example to me of how people with intellectual and developmental disabilities are impacting so many people's lives in a positive, beneficial way. I listened to one of the speakers earlier talk about joy. She spoke about joy, bringing joy to people's lives and smiles to people's faces in really difficult circumstances. And so I think the other thing it highlights is needing to take care of people as they age, and being in a community that they can call home so that they can be part of a family just like the rest of us. And so part of the work that Harold mentioned that he and I are doing is focusing on people with intellectual disabilities like Jimmy as they age, in order to best really to have a health system that best meets their needs and have that for everybody.
Wow.
All right.
Thank you. And
Thanks.
thanks for sharing about Jimmy. Sarah, I'd love to hear. I know you've got a lot of life experience, and that really includes sort of why you do what you do. So I'd love to hear from you.
Sure. Yeah. Hi, everybody. A quick description of myself, real quick, for folks who might be blind or visually impaired. I'm a white 50-year-old woman with kind of longish, curly red hair that's going gray, naturally, I might add, and proudly. And I have green eyes. I'm wearing a black shirt, a black, white, and gold print jacket, cheetah print, and pink glasses, and I'm sitting at my desk in my home in Northern California. I'm not in North Carolina, sorry, y'all. But I am a very proud disabled woman with bipolar disorder, and I also have a hereditary immune system disorder that I've lived with my whole life. And whenever people tell me, you don't look disabled, I tell them they don't look ignorant. But I've spent, most of my professional career making sure that no one else with a disability has to experience the same discrimination in healthcare that I have and that I still experience to this day, whether that was, repeatedly being denied health insurance because I had a pre-existing condition for most of my life, or to, the psychiatrist who I had been out on short-term disability, and I had was wanting to, get back into work, and I was actually being actively recruited by California Governor Brown's administration at the time. And I told the psychiatrist, okay, I really feel ready to go back to work. And she says, nah, I think you should just wait a little bit longer. Let's take our time. And I'm like, no, I'm being recruited by the governor of California. And she turned to the nurse in the room and said, I think we better check her medication levels because I think she might be hallucinating. So, just the expectation by the health profession and the kind of gatekeeping role that they play for so many people with disabilities like myself. But in my opinion, one of the biggest opportunities to improve health for adults with intellectual and developmental disabilities is to completely remove the federal and state requirements that make people like me with permanent lifelong disabilities, or those like with Down syndrome, making us reprove that we have a disability every year to continue to get essential health care like home and community-based services. It's quite possibly, in my opinion, the most ridiculous policy I've ever heard of. It wastes a ton of time, administrative, financial resources, and it just makes it harder for people with IDD and families to get care. So, yeah, with that.
Thank you. And I think that's a particularly important point in this moment where we're looking at work requirements and other things, or the Congress is, and saying that they're going to accept people with accept not require that for people with disabilities, but how do you fit into that disability category is a pretty critical question. Courtney, you are sort of the person who everyone has pointed to as a real leader in the home time space. So would love to hear from you about your own lived experience and what are the critical issues for you.
Sure, thanks so much. So my lived experiences as a sister of, had a big sister who had Russell-Silver syndrome and intellectual disability. And I was able to be at her side when she had a 22-day hospital stay and passed away at the end of that stay. So really, it was terrible. It was a really hard experience. I think the teams did as well as they could, but gosh, was that not person-centered care, and especially for intellectual disability and centered care. There were some good days and a lot of really bad days for us and for her in particular. So I had been working on home time measurement for a long time before this happened with my sister, and really thinking about it. Does this really, more time at home, it has to be associated and a real driver of quality of care, but we need to talk to people who are experiencing this to understand it. So I've been thrilled to be on this project where we will continue. We've learned so much in the last year, and we'll continue to engage and co-create with the IDD community and self-advocates so that we can understand how can we do better? How can we have person-centered care measures that really reflect the goals and preferences of people who are experiencing healthcare, and sometimes it's really poor quality of healthcare. So that's kind of how I got into this group, because of my measurement expertise, and also just a passion to try to improve quality of care that, as Sarah said, so people don't go through what our family went through.
So Courtney, one of the things that I have so loved about this project has been really listening to and centering, whether it's the advisor group, whether it's the research around people with lived experience. And for me as an advocate, it's critical, but there's also some tensions about sort of using people's story and including them. But at the same time, if we don't, it's sort of not what we should be doing. And so, how have you used lived experience in your research, and what are any pitfalls to it, and how do you reach folks with lived experience to make sure that you're really including them in your work?
Sure. So I'm a health economist by training, so I work with a lot of people who are experts in qualitative methods and interviewing and kind of engaged research. So I've learned tons from working with my colleagues at Duke and across the country. I think one of the things with this, what we're trying to get at in this project is really understanding from people's perspectives, what does being at home versus being in several different types of settings do for them? What does it mean are there differences in settings that we need to be thinking about if we're going to use this measure that essentially is a counting up of days that you're in different settings versus a day at home? We can't tell whether that day is a good day. This claims measure has a real appeal. We can count it up across multiple patient populations. We don't have to interview people. So if we find out what the best settings are to be thinking about, what the best timeframes are to be thinking about, then we can have assurance that this is, even though it's kind of crude, we don't know exactly what that day is like for someone. We know that it generally loads on quality of life, that we really will be able to use something where we don't have to interview every single person, and then we can really reflect population health. But I think for our job, as we continue to push in this area under Michelle and Bristana's leadership, really understanding kind of what does the time in a different setting mean for someone? What does the pain that you feel in a different setting mean for you? Are there settings we haven't even thought about? People in the project talked about dental care and the terrors of dental care and getting access to that. And that was not a setting that I personally had thought of. So the engagement with the community is just vital to be arriving at something that will matter and that will actually affect change.
Thank you. And so Harold and Kenton, the same question about how do you reach sort of harder to reach populations? How do you include folks with lived experience, and what are any pitfalls to doing so?
Ken, you want to start?
Sure, I'll go really quickly. One thing that comes to mind is a gentleman that we tried to engage as a consultant to get a patient perspective on on specific measures of healthcare access and things like home time. And as part of this, we wanted to pay him as a consultant, what we would pay anyone else in a similar position. And he was very excited to participate. His family was very supportive. But then when we got into the details of paying him, what would be not not a lot of money because it wasn't that many hours, it would have potentially jeopardized his Medicaid in the state of Missouri where I live. And so, unfortunately, that's something you got to think about, right? That I mean, and Medicaid's crucial for people. You don't want to jeopardize that. And so it also, I think, highlights a system. Harold mentioned ABLE accounts earlier, which is a way to shelter some assets, but there's also different state Medicaid programs have different income tests for Medicaid. And so that's a really important thing to keep in mind, because this is a situation where people want to be working, but yet if they work, they're gonna jeopardize their source of healthcare, which is really really sad. So that's something to keep in mind.
One thing I would add to that, if I may, is the importance of engaging people pretty early. And one of the biggest challenges that people have is what happens a lot of times, but when people are in K through 12 education, they're often getting a lot of services that are school-based. And then they graduate high school, and then what? And one of the most important ways we can engage families is to engage people uh, before that transition happens, and to say, okay, how can we make a plan for that? Uh, that tell us what you need. And so I think you have to build relationship before you need it so that it's there when you need it. And that's true in research, it's true in social service delivery, it's true in everything else. And um, here in Illinois, we have large waiting lists for disability services for people when they sort of go over that cliff from K through school-based to adult-based services. And I think that's just a key moment to build relationship and to help people navigate stuff. Because one of the challenges that we have in Illinois is that the well-resourced school districts have two really key advantages to help families. One is that they have a lot of resources that other places may not have. The other is that there aren't a lot of the competing needs are less profound. So if you're a school social worker at New Trier High School in Winnetka, which is one of the wealthiest cities in Illinois, the school social workers are spending a ton of their time on kids with disabilities and their families, helping them navigate these systems. They don't have as many kids who are homeless, kids who are having criminal justice issues, and so on. You go to the south side of Chicago, and the people that are helping families are just overwhelmed with so many other different issues. I'm sure in North Carolina, there's somewhat similar stories that can be told. So we have to really um, work on that transition, and especially in the communities where the helping systems are dealing with so many other challenges too.
Thank you. And so, Sarah, Harold just mentioned the waiting list, and we heard in the videos just how critical home was, and yet we know that there's waiting lists for services, that there are ways in which people just don't have access to home and community-based services. And so, my question for you is, what have you seen, particularly out on the West Coast? For ways in which states are trying to improve access to home and community services.
Yeah, the good news is, the bad news is the waiting list. The good news is there's a lot of innovative activity happening by state Medicaid agencies across the country, but a few more on the West Coast. The state of Washington is really leading the pack in this area. The problem I was just talking about before about having to reprove that you have a disability every single year to get home and community-based services. Well, in Washington, the state, for the most part, completely waives disability reexamination requirements for children with intellectual and developmental disabilities. They also have a CMS approval, and they've been implementing, it's called a presumptive eligibility process that speeds up your access to home and community-based services by allowing somebody or their family to self-attest that they have a disability while they wait to go through like the really lengthy Social Security and state disability eligibility process. And yesterday, U.S. Senator Eric Schmidt of Missouri actually just introduced a bill. It's called the HCBS Act, but it's Helping Communities with Better Support Act, that allows states to provide up to 60 days of interim HCBS for newly eligible individuals with IDD while they're going through that really lengthy eligibility process. Other states have created like HCBS in lieu of, HCBS Light, kind of in lieu of services that can be accessed while somebody is on a 1915C waiting list, waiver waiting list. So in California, there's over 10,000 people on the assisted living waiver waiting list, 1915C waiver waiting list. But the state recently started sharing the information on the people who are on that waiting list with the health plans, because the health plans are implementing these assisted living as an in lieu of service. So you can actually get somebody in to receive the services while they're waiting for their 1915C approval. So of course, a lot of this is dependent upon federal approval, which can shift depending on which administration's in power. But those are just a few examples of states that are doing innovative things to try and work around and get people services they need while they're waiting on an HCBS waiting list.
Thank you so much. And Courtney, I know you may have some things you've seen states doing, and I'd love for you to share anything that you've seen states doing to really increase access similar to what Sarah shared, but then also today's discussion is really about home time. And I think all of us have a pretty good understanding of it because we all have homes and we all know what time is. But can you tell us just a little bit more about what home time, how that is being used as a measurement, a little bit more just about what you're doing and how that really can be a key tool for understanding and use in research?
Sure. So far for the intellectual disability community, we are working on it to engage the community and understand what it should look like so that it's really tailored and to understand if it really reflects goals and preferences. In other populations in the VA, we've been working on it for about 10 years. And we've done interviews with veterans who have functional disabilities and dementia, talking to their caregivers and trying to understand what different settings should be included in a measure. There's researchers use this measure across the country, but there's no standardized measure. They call it many different things. So it's even hard to know the lay of the land. And so we try to look at 6 different settings and understand from qualitative interviews with people what are these settings like for them? What are the gains that you get and what are the things that you lose out on when you think about being in your home of choice? So we've really looked at it in terms of veteran populations. It's being used in lots of different ways to assess whether something works in treatment. So what happens if you have a surgery? Can we count the number of days that you, after that surgery, that you remain in a setting or go to post-acute care or have to go to a nursing home care, or then you finally get home? Can we count up all that time since a surgery to understand how that affects quality of life? CMS and public funders of healthcare are also interested in it as a performance metric. So perhaps more time in the settings is associated with lower quality of care. We know that's not always the case, but can it be used to reflect quality of care as well, and as a quality of life measure?
Thank you. And Kenton, I just wanted to follow up just on sort of your understanding of home and how that fits in with the work that y'all are doing, and any sort of additional sort of insights you have just from the video and from your own experience with L'Arche.
Sure. I think it's important to ask individuals themselves what they consider home to be. And so I think of people who are living in large homes and how it might show up in the data. To me as a researcher, it might be coded as a facility, but if you go there, it's like a home with 2 or 3 or 4 people with assistants who live in with them. And so sometimes when we just as researchers look at the data, it the data are filtered, right? It's not like experiencing reality, interacting with patients. And so what you're doing in this project is really important because it helps us to question how the data were generated and define home in a way that is meaningful to patients. Where do they want to be? Where do they want to spend their final days? For example, I think of the gentleman Jimmy that I mentioned earlier, who got to spend his final days in a large home with hospice brought there instead of having to be in a hospital or facility. And so it really is important as researchers to get patients' perspectives, because otherwise we just see the data, and the data are a function of reality, but not the same thing as reality. So
thank you. And Harold and Sarah, either of you or both of you, we've got just a couple minutes, so just a minute each, but we've got a lot of questions in the chat just about this time and the Medicaid budget and what the impact is going to be. And so, I guess I want to go in either a negative or a positive direction. What do you think the impact to home is going to be of this sort of current time? Or I also see this current time as a time to be getting ready for the next time where there's going to be more opportunities for the disability community. And so, how do you see this whole discussion around home, and either sort of what worries you about now or where you think we can go in the future? So, Harold?
Oh, Sarah, you want to go first? I think you may have a more tactile exposure to the policy process, and then I can follow.
Well, I mean, I would say, yeah, there's going to be significant impacts. I know though that like the protection and advocacy for individuals with intellectual and developmental disabilities, some of those have been protected, but the university centers on excellence in developmental disabilities in the bill are wiped out. So there's a real mixed bag there, but I think ultimately, it's really taking a swipe at that home and community-based infrastructure, which helps to keep people safe at home and having the quality of life that they want. And so I think this serves as a kind of awakening, at least for me as a person with a disability who's a part of the disability community, that our community is over reliant on federal funding and the support systems that support us are totally over reliant. And we need to start planning for other means to fund the life-saving and necessary care that we need to stay at home, because we're not going back. We're not going back to institutional settings. So we have to come up with an alternative.
Thank you. Thank you. And Harold.
I'll just add one or two things to that. One is I do think that we in the IDD community have a special role and responsibility to explain to the public the impact of these Medicaid cuts. One thing that's really striking to me is that the IDD community, people highly value the services that go to people with intellectual disability and developmental disabilities and their families. And there's really no public support for cutting those. And when we explain to people, hey, when you cut Medicaid, HCBS, when you eliminate the research funding that Sarah mentioned, that this really affects people with IDD, the public really responds to that. And I think we have a responsibility to communicate that. I think we also have a responsibility to communicate that there's so many other groups of people affected equally profoundly who don't have the same social standing. When I was thinking of in the video, the discussion of some of the mental health issues, and Sarah mentioned that she lives with bipolar disorders. One of the things that's really striking to me is that we in the IDD community can be leaders for a very large umbrella of people who live with all kinds of disabilities who don't have the same public standing and visibility. And I think we have a real opportunity to help people as part of a broad coalition. We had a project that was canceled that was helping people with ABLE accounts. And pardon me, I'm going to use some PG-13 vocabulary. When I would tell the story of our grant, I would have a real WTF reaction from most people when I described that our funding was cut to help families get ABLE accounts. And when people describe cuts to mental health services, you very often don't get the same, why are they doing that reaction? And I think we have a real opportunity in the IDD community to stand up for all Americans with disabilities that are affected by these Medicaid cuts right now. I'll stop there.
And I'll just say, whatever your sort of politics and whether you sort of agree with where we are now or where you don't agree with where we are now as a country, there was a lot of planning that went into this sort of moment of change for the government. And I believe personally that kind of planning to really build a whole new healthcare system that really values home is something that takes a lot of work, and we should be doing that planning right now, whether or not, and we should be doing that sort of building right now to be ready for the moment when it can really even build even higher. So with that, I'll turn it back to Michelle, but I'm really grateful for the panel and really grateful, Michelle, for all of the work that Duke University, my home school, has done.
That's right. Yeah, Duke proud for sure. So thank you so much, Tally, and to each of our panelists for this incredible discussion. I just also really want to thank everyone that was able to attend today. Thank you for doing your part to advocate for the unmet needs that the IDD community is still very much experiencing, and which our panel described so well. We do encourage you to visit our project webpage. You can do that through this QR code that you see visible here. And we also have dropped that link for our project page in the chat. You'll see summaries of our findings, access to video access to the video that we showed a clip of today. And we will also be in the next week sharing a recording of this, as well as a research priority brief that we would encourage you to check out as well. So lots of materials on that project web page. And then lastly, we invite you to share any feedback that you have for us, any questions that you have, and you can do that through our Hometime IDD at duke.edu email, which you also see on the screen. I just, again, thank you all and hope you have a great evening.